Assalamualaikum and hello everyone. My name is Halimatul Razia Osman. Today I am giving you a lecture on patient blood management, PBM, which is one of your topic for blood transfusion technology subject. Okay. Okay, these are the learning objectives for this topic. Before we discuss further the topic of patient blood management, I would like you to understand that every transfusion has its risks and benefits. Once you understand this, then you will understand why the patient blood management idea was triggered. Then I want you to be able to define what is patient blood management. And then finally, I want you to describe the strategies for patient blood management throughout the peri-operative period, which consists of pre-operative, intraoperative, and post-operative. As a blood banker, we need to know what are the benefits and the risks of blood transfusion. As we all know, transfusion is a life-saving therapy. It relieves the morbidity and reduces mortality rate when the blood transfusion is administered appropriately. However, the best transfusion practice is to only transfuse patients when there is a significant clinical needs. In other words, the benefits outweigh the risks. This diagram simplify what are the risks and complications following blood transfusion. So the first thing that is commonly associated with transfusion risk is the infection. In blood bank, we used to call it transfusion transmitted infection, also known as TTI. So this TTI can either be from virus, bacteria, or parasite. So this can happen when the pathogen are present in the donor blood. However, these pathogen, they escape the detection by screening assays. As we all know, there are limitations such as in serology assay, in which that the method is not able to detect antibody during window period. Okay, the second thing that is associated with transfusion risk is the allergy and immune transfusion reaction. This condition can occur in any patient, and it is more common in multiply transfused patient. For example, in thalassemia patient who needs regular transfusion. Okay, the next thing that is associated with transfusion risk is the volume overload. This volume overload is typically a concern in the elderly, small children, and those compromised cardiac function. So the next thing that is associated with transfusion risk is the hyperkalemia. Hyperkalemia can occur because of the potassium being released from red cell during blood bank storage. This hyperkalemia is a matter of concern, especially for patient who is having a massive transfusion, impact renal function, and also infants, newborns. So the last thing that is associated with transfusion risk is the iron overload. This iron overload is more common in a multiply transfused patient, which is among the thalassemia patient. Okay, now we go to the definition of patient blood management, PBM. According to WHO, PBM is a patient-focused, evidence-based, and systematic multidisciplinary approach to optimize the management of patient and transfusion of blood product for quality and effective patient care. PBM covers all aspects of patient evaluation and clinical management surrounding the transfusion decision-making process. Therefore, this topic is very popular among the transfusion community. Okay. PBM works by these three principles or objective. First of all is to maintain the hemoglobin concentration, the red cell mass, to minimize the blood loss, and finally to ensure optimal physiologic tolerance of anemia in an effort to improve the patient outcome. So these three principles are used to manage the anemia and reduce the risk of anemia itself, with the goal to improve the patient outcome. So when we reduce the transfusion, we are also able to reduce the risk of reaction as well as the complication following the transfusion. Okay, I hope at this point you are able to understand that patient blood management is never a single effort of this particular department. For example, an effort from surgery department alone or blood bank alone. Patient blood management initiative group can be formed at the hospital level or at national level upon discussion among the team. This patient blood management initiative group involves a multidisciplinary team of physicians from different specialties. This group must at least has representative from departments that are involved in the patient care. For example, a patient who is undergoing cardiopulmonary bypass surgery, the representative may come from the cardiovascular and thoracic surgery team, anesthetic team, transfusion medicine team, or cardiology or medical team themselves. However, who is initiating the group is always controversial. However, most of the time, it is initiated by the department that plans the surgery for the patient, which in this case is cardiovascular and thoracic surgery department. Okay, in other words, patient blood management initiative group coordinates the hospital care that the patient receive from physicians of different specialties. When we are talking about patient blood management, it involves the period of before and after surgery. So the common terminology that we use is peri-operative period. So this peri-operative period includes the pre-operative assessment, intraoperative, post-operative, and also the period when the patient is discharged from the hospital. Coincidentally, the PBM acronym for patient blood management is similar to PBM, peri-operative blood management. So this PBM, peri-operative blood management, refers to management of patient before and after surgery. So any information that the clinician obtain during the pre-operative assessment is used to create a care plan for the patient during intraoperative and also the post-operative period. Okay, now we are going to discuss in detail on strategies during pre-operative period. Normally, weeks or few days before the surgery, patient has to come to clinic for pre-operation assessment. At this point, patient blood is taken for few blood tests. For instance, blood count and also coagulation profile. Through this blood test, we are able to determine whether patient is anemic or not. So the clinician will assess whether the anemia is treatable or not. For example, if it's due to nutritional reason, then the patient is treated accordingly. At this point also, the clinician will determine whether there is a need for erythropoietin stimulating agent to promote erythropoiesis. Okay, surgery may also be delayed until anemia is resolved. From the blood test as well, we can determine whether patient has problematic coagulation profile. Bleeding history is evaluated and clinician may develop multidisciplinary plan for hemostatic therapy for patient with coagulation disorder. And for those patient who is currently on anticoagulant, the clinician will determine if there is any thrombotic or bleeding risk. So normally for a patient who is on anticoagulant, the clinician will discontinue the anticoagulant and will reinitiate back the plan of anticoagulant. Normally, surgery has minor or major type. So the clinician will determine the expected blood loss for that particular procedure. For patient surgery with expected blood loss more than 1 liter, the clinician normally will plan to prepare to use intraoperative blood salvage. Okay, this is an algorithm for the management of preoperative anemia. This is the simplified version of what I have said just now. Hopefully, it will help you to understand further. Okay, once the anemia is identified, the surgeon will assess the urgency of the surgery. Okay, if it's urgent, then there is no choice but to proceed with the surgery. Evaluation of anemia is done without delay, and in this case, sometimes transfusion is unavoidable. For elective case or non-urgent case, surgery can be delayed until cause of anemia is addressed and treated. For patient with iron deficient, the effect of iron treatment will be seen after 6 to 8 weeks. Management will include identifying the cause of iron deficiency. For anemia due to inherited condition, the surgeon may collaborate with hematologist or transfusion medicine service for further management. The goal of treatment is a little bit different, as it will not normalize the hemoglobin level. Okay, for anemia due to unknown cause or due to chronic disease, the clinician will collaborate with primary care team for further evaluation. There is a possibility to use erythropoietin stimulating agent for this category. Autologous donation is one of the pre-operative strategies. I'm sorry not to list this in the previous slide. Autologous donation means blood collection done from patients for patient own use. Normally, autologous donation is done few days or few weeks before surgery, but it cannot be too long because the product also has its expiry date. So far in my workplace, autologous donation was performed for cardiopulmonary bypass surgery. It has yet to be extended use for other case yet. Okay, the autologous donation has positive and negative um, points. The positive points are it reduces the risk of infection and also alloimmunization to donor antigen. Of course, you are receiving your own cell, therefore there is no issue of getting foreign pathogen as well as immune reaction towards foreign antigen. The autologous donation is very good for patient who is known to have rare blood group. So compatible blood is available for this patient. The negative points for this strategy is the cost of performing this procedure is a bit costly. um, the other point is the patient may experience adverse reaction during collection and also iatrogenic preoperative anemia secondary to autologous donation. Okay, now I'm going to talk about the intraoperative strategies that can be implemented under patient blood management. For patient that undergoes non-cardiac surgery, there is a need to maintain fluid balance in which large volume of crystalloid solution should be avoided. Second, putting patient in cold condition shall be avoided as well. Also, there is a need to use meticulous or detailed hemostatic techniques during the procedure. Topical hemostatic agent can be used when appropriate. Okay, for surgeries that has expected blood loss more than 1 liter, the use of intraoperative blood salvage is recommended if appropriate. Okay, by the way, this intervention has also been performed during cardiac surgery at a PPU ITM. Administration of antifibrinolytic agent such as like tranexamic acid can also be used. This TXA promotes blood clotting. At the same time, it can be used as a painkiller. It is recommended to use evidence-based guidelines such as transfusion trigger when there is a likelihood of blood transfusion. Um, Transfusion trigger based on certain level of hemoglobin is used in this situation. Another intervention is the possibility of using acute normovolemic hemodilution, also known as ANH. Okay, as I mentioned in my previous slide, there are two type of intervention that can be used during intraoperative period. They are acute normovolemic and also intraoperative blood salvage. There is a slightly different between these two intervention. For acute normovolemic hemodilution, this is actually a blood conservation technique that involves the removal of whole blood from a patient shortly after induction of anesthesia into standard collection bags with maintenance of normal volemia using crystalloid and or colloid replacement fluid inside the patient body. And this hemodilution reduce cell loss. The blood in the collection bag must be reinfused back to the patient within 8 hours. This blood contains coagulation factor and also functional platelet. The intraoperative blood salvage is also a blood conservation technique. However, this is specific. This is a specific type of autologous blood collection. Specifically, intraoperative blood salvage is a medical procedure involving recovering blood loss during surgery and reinfusing the blood into the patient. It is a major form of autotransfusion. This one, when the blood is recovered, the anticoagulant is added and the blood must be reinfused back within 4 hours. So, intraoperative blood salvage doesn't involve crystalloid or colloid volume into the patient. Okay, now I'm going to talk about post-operative strategies that can be implemented under patient blood management. Okay, majority of the patient that undergo non-cardiac surgery, it is recommended to minimize the blood sampling and also to use any evidence-based transfusion guideline, which means based on the guideline, there is a transfusion that is allowed for certain level of hemoglobin. If the hemoglobin is more than, for example, more than 8, it is not recommended for any blood transfusion. But if it's less than that, less than 7 or 8, transfusion is recommended. For patients who have excessive bleeding, um, early surgical re-exploration is recommended for those with localized internal bleeding. And cell salvage in selected case with large external blood loss is also recommended. And it is also recommended to perform lab testing and also hematology tests for those with diffuse bleeding. For those patients who experience anemia after surgery, the iron deficiency anemia is re-evaluated in a selected case, especially preoperative anemia or microcytosis that was not evaluated before surgery, and also if there is an excessive blood loss. So for the anemia, for patients who experience anemia after post surgery, it is recommended for the patient to go for ongoing treatment and has a follow-up. Okay, these are the questions that can be considered when planning patient blood management for patient undergoing orthopedic surgery, and also cardiovascular surgery. These are actually American Association of Blood Banks recommended question that can be considered for patient blood management. As you can see here, the question covers the aspect before surgery, during surgery, and also after surgery. Okay, patient blood management is relatively not a new concept because it has started since 2012 under the Choosing Wisely campaign. This Choosing Wisely campaign is not dedicated for blood transfusion only, but other aspects of patient care. This Choosing Wisely campaign has spread to many countries from America, Australia, Canada, European countries, Japan, New Zealand, to name a few. Okay, for Canada, there is a campaign, If One Unit Will Do, Why Transfuse Two? The tech has put the patient care team to carefully consider a transfusion as something that it is done only when it is necessary. Okay, the American Association of Blood Bank USA has also come up with 5 things physician and patient should question in relation to blood transfusion. First, don't transfuse more units of blood than absolutely necessary. Second, don't transfuse red blood cell for iron deficiency without hemodynamic instability. Third, don't routinely use blood product to reverse warfarin. Warfarin is anticoagulant. And fourth, don't perform serial blood counts on clinically stable patients. And number 5, don't transfuse O negative blood except to those O negative patients and in emergency for women of childbearing potential with unknown blood group. Okay, the UK has also come up with 5 recommendations related to transfusion. First, it is recommended to discuss the benefit and the risk of blood transfusion with patient prior to surgery. Um, the second recommendation is only give iron to iron deficient patient. Do not transfuse red cell unless the iron deficiency is treated. And the third recommendation, save OD negative blood. Only transfuse OD neg red cell to OD negative patient and in an emergency for female of childbearing age. The fourth recommendation is to review um, after each unit. Review the patient after each unit. Use only restrictive threshold for patient needing red cell transfusion and give only 1 unit at a time, except when the patient has active bleeding. And the fourth recommendation related to transfusion is if the patient is under chemotherapy, platelet is only transfused when the count is less than 10 to the power of 9 per liter. Okay, now I want to discuss a little bit about a group of people who refuse blood. Okay, they refuse blood because of religious reason. For example, for Jehovah Witness uh, uh, patient. Okay, it is very important to understand and identify the group. Normally, when the patient is warded, the texts are given to the patient. Especially this is done in overseas. I don't think in Malaysia we have done that yet. The same principle of PBM can be applied, but for this category of patient, there must be like sort of like different approach to handle this particular group of patient. The components we need to know the components that they refuse, the components that they consider to accept, and the components that they accept without reluctance. So there must be some sort of like discussion on strategies and option between the patient and also the healthcare provider. Okay, as a conclusion, PBM's aim is to improve patient outcomes through the safe and rational use of blood and blood products, and also by minimizing unnecessary exposure to blood products. So For now, we need to understand that PBM is a multi-professional, multidisciplinary, patient-centered approach between stakeholders who have role in patients' diagnostic and also therapeutic care. So as we discuss in detail, the strategies differ at each stage or period. I mean, during the pre-operative, intraoperative, and also post-operative stage. Okay, in this cartoon, PBM is actually some sort of art. Art. So if there are any question, please contact me through this email. Thank you so much.